Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 539 of our pharmacotherapy series, which majors in anxiety disorders. This case applies to patient RCG in part 538 of this pharmacotherapy series. After 4 weeks, RCG is taking fluvoxamine 200 mg daily and tolerating the medication well. She complains she has not noticed much improvement, and her Yale-Brown Obsessive-Compulsive Scale score, abbreviated as YBOCS score, is slightly decreased at 30. RCG has been to the cognitive behavioral therapist twice, but is reluctant to return because the therapy was so stressful. RCG requests to be switched to a more effective medication, and she also asks to be given some alprazolam to help calm her anxiety during behavioral therapy sessions. What is the best course of action for RCG at this point? Switching to another medication is not recommended at this point because not enough time has elapsed to assess fluvoxamine's efficacy. RCG is tolerating fluvoxamine well and has shown a mild improvement, so this medication should be continued for at least another 4 weeks. Additional counseling information should be provided to RCG to emphasize this fact. An increase in fluvoxamine dosage, up to 250 or 300 mg per day, may be considered after several more weeks because some patients may respond better to higher dosages. If RCG's symptoms continue to cause significant functional impairment after 10 to 12 weeks of higher dose fluvoxamine therapy, a change in treatment, e.g., switching to another selective serotonin reuptake inhibitor or augmentation therapy, will be indicated. RCG should be encouraged to continue cognitive behavioral therapy to optimize the chance for successful treatment. An anxiety response is integral to the therapeutic benefits of behavioral therapies. Because benzodiazepines can blunt this response, they may reduce their efficacy. Therefore, alprazolam should be avoided, and a temporary reduction in the intensity of behavioral therapy may be indicated instead. Fluvoxamine can also inhibit the CYP3A4-mediated metabolism of alprazolam, resulting in more pronounced effects from a given dose. After 5 months of treatment, RCG is happy to report her obsessive-compulsive disorder is much improved. Yale-Brown Obsessive-Compulsive Scale score of 11. She still has intermittent obsessions related to contamination and doubting, but they are less intense than before. She is usually able to resist urges to clean and wash excessively and is using the stairs in their home with only mild discomfort. Her previous employer has agreed to let her return to her secretarial position when she is ready, and she plans to do so soon. RCG's husband is extremely pleased with her progress. Their primary question at this visit is whether treatment can be discontinued now because RCG is doing so well. The next question reads, what recommendations should be provided regarding the long-term course of therapy for RCG? This case illustrates a common outcome of obsessive-compulsive disorder treatment, in which some symptoms persist, as evidenced by a Yale-Brown obsessive-compulsive scale score of 11, but significant improvements in functioning occur. It is currently recommended that effective treatment for obsessive-compulsive disorder be continued for at least 1 year after response to reduce the risk of relapse. Therefore, continued drug treatment for at least 7 more months is indicated. Results from several studies suggest decreased medication doses, with selective serotonin reuptake inhibitors and clomipramine during maintenance therapy are comparably as effective as full doses in preventing relapse. If RCG was experiencing any fluvoxamine-related problems, a decrease to the minimally effective dose, 150 mg per day, during maintenance therapy might be recommended. After a 1-year maintenance period, discontinuation of medication may be considered by carefully weighing the possible risks and benefits. When medication therapy for obsessive-compulsive disorder is withdrawn, the dosage should be gradually decreased by approximately 25% every 1 to 2 months. Continuous monitoring for signs of relapse is required during this period. Gradual discontinuation also lessens the chance of the withdrawal syndrome often occurring after abrupt discontinuation of selective serotonin reuptake inhibitor or tricyclic antidepressant therapy. Long-term or even lifelong maintenance pharmacotherapy is usually recommended after 2 to 4 severe relapses or 3 to 4 less severe relapses. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arua, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 540.